Dr.
Okay, thanks.
Parthasarathi?
Yes. Can you hear me, sir?
Dr. Parthasarathi is online?
Yes.
Yeah,
Can you
doctor,
hear me?
your video is not on.
Yeah, sir, there is some issue with my video. Can you hear me, but?
Yeah, I'm able to hear you.
Okay, sir. I am not able to use my camera. Some issues.
But then, are you able to project your slides?
I think slide share will be okay.
Okay, then it's
I can try that now if you. Can you see my slides?
Yes, we can see.
Okay.
Hello. Good evening, சொல்லுங்க. நீங்க வந்து மொபைல் எடுத்துட்டு அங்க வந்துருங்க. ஹாஸ்பிட்டலுக்கு அங்க இருந்து நம்ம ஃபோன் பண்ணிக்கலாம். சரியா? ஓகே. ஃப்ரைடே. நாளைக்கு வரலாமே. ஆமா, நாளைக்கு 7 o'clock. ஓகேவா? ஓகே.
Okay. So can we start then?
Yeah.
Okay. So welcome everyone, all the delegates and the faculties to the No Thrombosis National Workshop event. So today we have our course director, Dr. P. Muthukumar. He's a senior consultant neurologist, Apollo Specialty Hospitals, Chennai. A highly skilled neurologist with over 20 years of experience in medical field. He's a facilitator for annual courses in neurosciences conducted by the Tamil Nadu Dr. MGR Medical University. He has a notable expertise in digital subtraction angiography, toxin therapy, neurointensive care, and many more. He has presented several presentations in national and international conferences, and he has affiliations with several academy and association like Indian Academy of Neurology and Indian Medical Association. Welcome, sir.
Yeah, thank you for your kind words.
Okay, sir. We have our first moderator, Dr. K. Bhanu. She is the Director of Neurology and Neurosurgery, Mehta's Hospital, Chennai. She was the first Director in Institute of Neurology, Madras Medical College, Chennai. She has edited 4 books in neurology, journal publication 176, and chapters in books around 16. She also has presented many presentations in national and international conferences. She has received IBE award through IEA for vocational training program for women with epilepsy, started making classes at RGGH. She has around unblemished service of more than 25 years, awarded by Government of Tamil Nadu, received FRCP London 2016, FIAN 2019, also received Mayan Award of Public Service March 2016, received Commonwealth Fellowship in Neurology at UK, Eminent NBE Alumnus Award 2018, Lifetime Achievement Award by IMA, Best Teacher Award by TN Dr. MGR Medical University, Atlas Elsevier Award 2015, Master Teacher Award Shine 2022, Legion in Neurology SINA 2022, and been examiner for many exams. Welcome, ma'am.
Thank you very much for making me a participant here. Thank you.
Yes, ma'am. We have second moderator, Dr. S. Meenakshi Sundaram. He is working in Apollo Hospitals, Madurai. He has also more than 20 years of experience in neurology, also participated in many research work and various workshops under the neurology department and published many papers. He is affiliated with many societies like Neurology Society of India, Indian Academy of Neurosciences, and American Academy of Neurology. Welcome, sir.
Thank you, ma'am.
We have our first speaker for today's meeting, Dr. Ritesh Nair. He has finished his MBBS Calicut Medical College, MD from Coimbatore Government Medical College, DM from Bombay Hospital and Institute of Medical Science, FINR from Department of Interventional Radiology, KEM Hospital. He is currently working as consultant interventional neurologist in Hospitals, Chennai. He has also been a membership of many associations and presented papers and speaker in many conferences like presentation in Bombay Hospital Annual Research, and also got the Best Research Paper Award for research presentation in 2007. He has many publications and has an experience of over 2,000 independent neurointerventional procedures, including intra-arterial stroke thrombolysis, mechanical thrombectomy, etc. Welcome, Dr. Ritesh Nair.
Thank you, ma'am. Thank you. Good evening, all. Thank you.
We have our second speaker for today's meeting, Dr. Partha Sathi. He is a consultant neurology Apollo Adlux Hospital, Kerala. He has over 8 years of experience in neurology and post-GM training. He has post-GM training in epilepsy from SCTI MST Trivandrum. He has got best paper in ECON, blue ribbon paper MDSI Con, lead program MDS International. He was also guest faculty for state level PG training program, and he has done his MRCP from UK. He has also his publication in national and international journals and participated in international clinical trials. Welcome, Dr. Partha Sathi.
Thank you. Thank you.
And now, without wasting any more time, I would like to hand over to our program director. So, over to you.
Yeah, good evening to one and all. Welcome everyone to this No Thrombosis National Workshop. So, see, there are a few things in stroke we have to remember, particularly the TPA approved in 1996. That was a very special year in stroke management. And subsequently, the tenecteplase approved in India in 2016, that stroke management. There are many things in stroke is in black and white. For example, the IV thrombolysis and mechanical thrombectomy, and many things are in black and white, like recommendations by Indian Stroke Association or the American Stroke Association or World Stroke Organization. But there are still certain gray areas are there. So the purpose of this kind of discussion and meeting is to dissipate the knowledge about the stroke in that gray areas, to discuss about this gray zones with experts. Okay. So example that dissection, this intracranial or extracranial dissection, how to go about, whether we will go by intra venous thrombolysis or mechanical thrombectomy, or straight away we are going with that antiplatelets or something like that. That will not be in current recommendations. It's not very clear. So one of a case discussed by Dr. Parthasarthi today is like that. Then second one, Dr. Ritesh Nair to be discussed is this one more gray zone today. So for all the listeners, listen carefully the eminent speakers, Dr. Ritesh and Dr. Parthasarathi. Then we'll discuss at the end of their presentation, and our experts, Professor Banu Madam and Dr. Meenashundaram is there. So we'll have a fruitful discussion. In stroke, always 4 P's we have to remember. One is pipe, second one is the parenchyma, then penumbra, and fourth one is the perfusion. So with these words, I call upon the first speaker, Dr. Ritesh Nair. Over to you. Ritesh?
Sir, good evening, sir.
Yeah.
Audio is clear.
Yes, we are seeing your slides.
Yeah.
Okay. Audio is clear.
Yeah, it is clear.
Yeah,
now.
audio is clear.
Yeah. Good opportunity, and we have a good panel of.
Ritesh, 1 minute. Can you make it into a slideshow?
I think I can by the person there.
Please
start
Dr.
the slideshow.
Pratiksha, can you make this into a slideshow? The host? Who's the host? Can you hear me, Dr. Pratiksha? You're muted. Yeah.
I was muted and talking. So yeah, I made it to slideshow. So I'm doing it again. Please let me know if it is in the slideshow or not. Yeah. I've done it as slideshow. Is it
No,
possible?
it is not in slideshow.
Why it is not happening? Okay, let me share it again.
If you're not able to do it, we'll go with that view only. Doesn't matter.
I'm just trying my best.
You kept it open at the bottom?
Okay, no.
I think it's okay.
yeah.
Yeah. It is in
Now it
slideshow.
came.
Yeah.
Diksha?
Okay, great.
Okay,
Yes,
ma'am. Thank you.
Ritesh. Right.
Thank you. So we know, sir introduced that for last more or nearly 30 years we are been following IV RTPA, and only last 8 to 9 years. We have a preference for elderly. We prefer IV RTPA maybe because anytime there is any, we are giving it over 45 minutes to 1 hour infusion. So any headache, anything we can stop. Tenectase has its advantages and little disadvantages. So Tenectase, one advantage as a neurointervention is we save a lot of time in the CT console, CT outside the CT recovery itself. We can give as a bolus. It's hardly a 5 minutes thing. Then we can BP is high, we can lower the BP. And if the patient is not improving, we wait, usually counsel the family to care. It saves a lot of time. So I'll be
Ritesh, your voice is bit breaking. On and off, its voice is bit breaking.
Yeah, sir. Now it's audible, sir.
Now it's okay.
Sorry, sir. So I will be sharing one case which we did some 5-6 months back. So next slide, please.
You can sir, you can turn off your video, and then it might be better because sometimes the bandwidth.
Okay, it takes more bandwidth.
Yeah,
I'll do that. Now it's audible.
Yes.
Yeah, this is a 40-year-old male. He has an history of epilepsy. He was accompanied by his wife. This was middle of the night, around 1 a.m. in the morning. So he has history of epilepsy. In the night when he came out of the restroom, his wife noticed that his speech is little slurred and his right arm was not moving. So they stay very close. They came to the ER within 1 hour of the onset. So he had decreased speech output and right upper limb weakness. So the past history of epilepsy and the details were not known. So anyway, our juniors in the ER, usually in the late hours, we have given them the protocol is follow MRI. So on examination, he had motor aphasia and right upper limb was around 2/5. And by occupation, he's a teacher for last 25 years. He teaches in a college as an English professor. He was immediately shifted for MRI. Next slide, please. So we have a clinical localizer for left MCH stroke. And this was the diffusion on the left side. You can see early diffusion changes in the left temporal lobe as well as in the posterior parietal. And the right slide shows the circle of Willis as a coronal view. We can see that MCH is very pruned out and hardly any flow. So we know it's a large vessel occlusion. So we analyzed that it was shared in our WhatsApp group. So patient is less than 1.5 hours of the onset. Next slide, please. So we completed, because no details were available of the epilepsy thing. So we completed the full MRI sequence, which additionally take 10 minutes. By the time I can arrive or whatever it is, if they are willing for thrombectomy or IV thrombolysis. So one incidental finding we noted was he had a lot of vascular flow in the right temporal lobe. So he definitely had a right temporal AVM. That was his cause of epilepsy, which the wife was not able to communicate. Here is a little dicey situation. We know AVM the patient has AVM. It's a definite contraindication for IV thrombolysis. And but the patient has a large vessel occlusion, the MCA. We counseled the family. We told them there's a risk of undefined risk of bleed. Lab. Next slide, please. So patient in IV window for IV RTPA or Tenectase, right temporal AVM, however, high risk of ICH with IV RTPA was immediately taken to the cath lab. Next slide, please. This is what the intervention per slow.
Ritesh, your voice is once again breaking.
View is coming. Sorry, sir. Now I'm still only. It's audible, sir?
It's better now. It's better now.
I'll go slow. So the slide on the left, which is an AP view, shows that anterior cerebral artery territory is filling very beautifully, but the left MCA territory is very slow. So there is definitely a thrombus somewhere, but there is M1 is not cut off. So that is a magnified view of that I have shown in the right slide. So you can see one thrombus sitting in the right and distal M2, M3 portion. That is post-Sylvian.
If possible, you can use your marker that in your...
Sir, I'll show this. Next slide, please. So that is a thrombus, sir. So this was a thrombus in the distal M2, almost after the Sylvian, we call it M3. So distal M3. Distal M2 or near the M3. So this was an important branch. It's actually superior division, which is supplying the hand area as well as the Sylvian, the Broca's area actually. So next slide, please. So this is an oblique view. Same thing. We can see there is a slow flow in the middle cerebral artery territory, particularly that temporal region. And the view showed a definite thrombus in one of the branches of MCA, that is M2 and beyond. So as an interventionist, going there and reaching with stent retriever is little risky because there are stent retrievers available for this artery also now. A lot of the Western countries, they do this medium vessel occlusion also. So, and there is a high risk of perforation because this is a very taut. So reaching pulling out the clot may not be that advisable, and there's a little high risk of rupture of the artery. So what I suggested was we'll use, though we are not using IV here, IV small dose of intra. We counsel the family, we told, though we'll using only 1/10 of the dose, there's a good chance of lysis. So we decided on IV tenectase. Next slide, please. Sorry, intraarterial tenectase.
IV tenectase. IV tenectase.
Sorry, intraarterial tenectase. So next slide, please. This is where you are taking a microcatheter distally into the artery. Next slide, please. We do a check shoot, so we can see this is the artery where it's having thrombus and hardly any flow artery. So one small thrombus has caused a lot of deficit, and that too a teacher by speech is so important. So we were lucky. I have given around 6 milligram of considering he will have having a body weight 80 plus. So we use usually up to 10% of the body weight we can use. So up to 8 he can go. We use 6 milligram of tenectase here. So this is on the division. One branch is actually supposed to supply the Broca's, other branch is supposed to supply the hand area. Next, please. So we give tenectase over 15 to 20 minutes, very slow. Since the thrombus was in distal MCA, we didn't advise thrombectomy. So IV tenectase was given. Next. Fortunately, we could recanalize that artery. We can see now the ACA as well as the MCA at the same timing in the mid-arterial phase. And you can see on the right slide that artery has opened up. Both the branches are filling. One is actually the one goes to the hand area, and the lower one is the one supplies the Broca's area. So this was done under general anesthesia. Small artery is going is better. And he was little on the rest. So right away.
We lost you. We lost you, sir, doctor.
Ritesh, we are not audible,
Yeah.
Ritesh.
Next slide.
Ritesh, your voice is not audible.
Oh, we lost him. Dr. Ritesh, can you hear us?
Can you hear me?
Yeah, now it's okay. Ritesh?
Yes, sir. So we extubated the patient in 1 hour time post procedure, maybe around 2 o'clock to 2:30 in the morning. He was making words. His speech had definitely improved. Upper limb improved over next 24 hours. So the point is, tenectase is a very good fibrinolytic thrombolytic agent. So, and we have that advantage. If you're giving in situ, when we all got trained 15, 20 years back, our only weapon was intraarterial RTPA. Because the only disadvantage is if it is a large thrombus in a proximal M1, even we give a very slow injection over 45 minutes, it's a cumbersome. Sometimes we definitely can't open the thrombus. So then what we used to do is we used to use a coronary balloon, actually split the clot mechanically, because we didn't have stent retriever that time, 2007 and all. And we used to give intraarterial RTP over 45 minutes. So selected cases like this, we are very fortunate we picked the AVM because it was an MRI. Selected case like a distal thrombus, we can definitely use intraarterial, small dose of tenectesis. Usually 10% of the body weight we use. That is the upper limit we use. And this patient came after 3 months. We did treat this. He was found to have an aortic plaque, which had mostly gone into which is embolized. He had a soft plaque in the arch of aorta. He had a very high cholesterol and definitely a family history of stroke also. His elder brother had a stroke at the age of 50 something. So we told here you have to be on lifelong antiplatelets and high dose statins. And we treated his AVM after 3 months. In March, we treated. Now he's back to his work, is normal. So just selecting this case was still there is definitely use of intraarterial thrombolytic agent in distal thrombus. So they do wonders actually. They lies when we are giving near the thrombus, small dose over 10 to 15 minutes, definitely it helps. Thank you, sir. Thank you, madam.
Ritesh, can you just highlight the dose? I didn't understand. Tenectesis intraarterial dose.
10% of the body weight.
Okay. So that instead of 0.2, it is 0.1, is it?
Yes, ma'am. Less than 0.1, ma'am. For he was around 80 kg. So we have decided we won't cross 8 mg.
8 mg. Okay. Right. And how did you manage the AVM? What did you do?
AVM, we did embolization after 3 months, ma'am. Okay. Because I told, because your epilepsy also may little get controlled. He used to get focal seizures somewhat once or twice a year. And 1 or 3 episodes of secondary generalized seizure also happened because he used to take some night tuitions at his place. So sleep deprivation was always there.
Okay.
We embolized, madam, after 3 months. Thank you, sir.
Nice.
Thank you, madam.
Right. Very nice case. Improvement in aphasia seconded so much of a difference, more than the hemiparesis.
He's a literature professor.
Okay. Very nice.
So very nice presentation, Ritesh, and it's a very nice case also.
Thank you, sir.
So in the midnight, you save the patient's speech and the right upper limb weakness. So Ritesh, the recommendations for intra-arterial thrombolysis with the tenecteplase. Can you elaborate to the audience about the ISA recommendation and American Stroke Association recommendation?
Sir, the dosage this is a consensus dosage in most of the national and international.
Your voice is breaking, Ritesh.
This is a consensus from experience-based interventionists all over, I think globally as well as nationally. They recommend.
No, still it's not clear.
Hello, sir.
Still
Hello.
Now it's okay.
Okay. So the national conference and global conferences, they say 10% of the body weight is upper limit, is highest. So definitely in obese Western countries, they will go up to 20 kg and all, 20 milligram and all. So in our experience, we have never crossed more than 10, sir. So I think the more data comes, then there will be definitely guidelines. But it is all individual selections. But distal small thrombus, definitely a lower dose is enough.
Because this will be slow infusion. The guidelines suggest slow infusion where Dr. Ritesh has performed. So I think that is the key. Even in STEMI, they have to give intracoronary, they will give always a slow perfusion.
Low? Sorry.
So what you did slow infusion, I think that is the key here. Even in the guideline, they suggest, even in intracoronary, they will give as a...
What happens, no, we used to do that initially when I was saying, no, for 45 minutes, we have to give. So what happens, we used to give as a small infusion pump and give. But at that point, that the catheter is remaining there for 45 minutes itself induced thrombus in the proximal eye. So that's a little, so that way we take a Suppose this is 8 ml, we take in a 20 ml syringe, dilute with saline and slowly give over 15 minutes. Because the more the catheter stays there, it itself induces a thrombus.
It induces, yes.
That's
yes.
Yeah, so sometimes even it causes spasm, then all our effort become futile.
So
How
you gave
many
it over
patients have you
15
given
minutes.
intra-arterial, Dr. Ritesh? Dr. Ritesh? Hello?
Ritesh? Once again, his mic is not working. Yes, sir, your comment about this. Sir, you are audio. Yeah.
Muted. Yeah.
Sir, Dr. Ritesh, it was a fantastic disposition, really. First, my many congratulations to you. Phenomenal, really. The way you took it across, absolutely brilliant, in my opinion. Now, we had our own experience of intra-arterial tenecteplase. This was much before the time we started using mechanical thrombectomy. And in fact, the first use of intra-arterial tenecteplase we did was a very accidental thing. A patient was with us with mitral valve disease and was due for discharge, at which point of time she suddenly developed stroke. And this was one of those scheme cases. They didn't have money. This happened inside the hospital, and we decided that we'll go ahead with that. And I decided to take the patient for, because the previous day or so is when she has undergone mitral valve surgery. This one was interventional, the dilatation or something. So we decided we'll go ahead with the intra-arterial tenecteplase. This was much before the approval of tenecteplase for our country. I think it was 2012. So we took the patient inside, explained to them that is not approved. In fact, we wanted to only go ahead with altiplase. When altiplase was not available, and this tenecteplase was available with the same Emcure with the other, this tenectase was not available at that time. The other one, what is that, Dr. Amit? The other one, the name?
Elaxim.
Elaxim was available. Our own cardiologist, Dr. Karpia, he had one sample of Elaxim, and we decided, we spoke with the family, and we said, this is not approved, but this is the only way we can do. They said, fine, go ahead with that. We did that, and brilliant improvement in the patient. NHS score, I don't remember the NHS score subsequently. The next day is, something said, Dr. Karpia told me that SMS you might have treated TAA, he told me. That was the improvement which he had. Then I told said, this is absolutely ridiculous because it's absolute improvement you have seen. So we did the MRA repeat on the patient next day. All these things were free for the patient actually. So the MRA was done before the I8 tenecteplase, and we repeated the MRA. And believe me, the MRA, the second MRA showed larger infarct, not a smaller infarct. And the patient was absolutely okay. We discharged the patient, and this patient we published in the Journal of Neurological Sciences. We published it. It is available freely on the net, intra-arterial tenecteplase in a patient, much before the advent of mechanical thrombectomy. So I'm really thrilled to hear this case from you, which we did earlier. That's first thing. In this case, AVM, when we look at that, AVM is a relative contraindication, I thought. Is it an absolute contraindication? We could not have gone ahead with it because there are publications of arteriovenous malformations being present there. And we have also thrombolyzed patients with IV, altiplase in those days with the AVM there. Is it an absolute contraindication, sir?
So I believe so. We don't know the morphology of AVM. If there is an intra-arterial aneurysm, intranidal aneurysm or something, there is a risk of bleed. If there is a BP shoot up or something, because we are having next 6 hours, there will be lytic in the system. AVM is a very unpredictable disease. It's not like aneurysm. Aneurysm, we can just seeing the morphology, shape, location, we can say what is the risk. If it was an aneurysm, I would have gone ahead and thrombolized. Okay. But AVM...
Is it the absolute contraindication I want to learn from you?
No,
because
sir.
I read it
Knowing
only as a
AVM,
warning. It was not mentioned as an absolute contraindication. It was a warning, I thought. Is it correct?
No, sir. Patient with a known AVM is an absolute contraindication.
Because I remember, because I recently, presented at TANCON also, I was reviewing that. I thought it was a warning in this one and not as an absolute comment. Anyway, somebody can look up and then inform us. That's a good knowledge for us. And Dr. Amit, you can just look into it and teach us. whether it's an absolute
Sure.
contraindication or getting in the warning list. That is first
Yeah,
thing.
I'll just check and confirm.
You can check before the meeting is over. We'll have a learning point on that, because my idea is that it is a warning, because we have done that in the past. Using this as a warning, we have done that in the past. That's why I'm mentioning this point.
Although, so they are saying it's a contraindication. It's not a relative. It's a contraindication.
Thank you, Dr. Ritesh. That was an important point. And thirdly, why this patient developed a stroke?
When
So young.
he had a very bad cholesterol. So triglycerides were more than 300, and he has a family history. His elder brother had a stroke 6 years back, something at the age of 50. He had an aortic plaque. Actually, there was a soft plaque in the ascending aorta, which was an irregular plaque, very vulnerable like plaque. Mostly it would have ruptured. He would have strained for urine or something. Maybe that's what happened. He went to the restroom, came back with.
Can I have my video, please? It's not able to log in, though you're asking me to put on my video. It's disabled. Dr. Ritesh, I have a question for you. How many how many intraarterial tenective plays have you given?
Tenectis around 5, ma'am, 4 to 5. Most of the strokes we go with the stent retriever, thrombectomy only, ma'am.
Okay. And tenective place has made our life much easier than with active place.
100%.
Because at least you will just give it off immediately, rather than all the
only
other procedure.
Maybe little apprehensive in elderly who has a fluctuating BP and all.
Yeah. Okay.
Ritesh, I have a question to you.
Yes, sir.
Yeah, there are certain trials like Angel tenective place trial, and that's a British tenective place 2 trial.
Okay.
Can you throw some light about the mechanical thrombectomy plus intra-arterial thrombolysis?
Definitely, sir. It depends on the size of the and character of the clot. Patient coming in an IV window, give the IV tenectase. If it is a large vessel occlusion like a T occlusion or a proximal M1 occlusion, MCA, most of the time we have seen one patient recovering on table. I have a video of a patient whom we have given tenectase. Patient was not recovering. We take him to the cath lab. I am doing an angio. We can see the clot lysing. He was a young patient, some 37-year-old. So I believe tenectase definitely helps in making the clot soft. So we have to just give some 30 minutes to 1 hour. He was shifted to cath lab. I still remember his name, Selvaraju. He was a spot boy in the film. This happened in the morning time. He was shooting somewhere in the Prasad studio. He found aphasic left MCA total occlusion. We gave tenectase. Then we took him, but the patient has not improved on table. So whatever the trials say, but tenectase do wonders in even bigger clots. So maybe 70 to 80% we'll have to go for thrombectomy. 20% it is 20 to 30% it is effective in even large vessel occlusions. So any patient with a LVO less than 80 in the IV window, large vessel occlusion less than 80, we prefer now tenectase, whoever comes in the 4.5 hours.
Any other question from?
Anything in the chat box, Dr. Muthukumar? I don't think we can see the chat box.
No, currently there are no questions from the attendees.
No questions from the attendees.
No, any question from the audience?
No, sir. Currently there is no question.
Okay, then shall we move on to next presenter?
Yes, please.
So, just Dr. Amit Saraf joined, and just for the benefit of the audience, just want to introduce just one line. So Dr. Amit Saraf is from the R&D of Genova, and he has been instrumental in launching tenectase in India, and has been instrumental in developing this molecule and bringing in India. So thank you, Amit. Yeah. Sorry to interrupt, sir. So over to you.
So we have one question which has just come up. Can I just say it?
Yeah.
So the question is, can we thrombolyze with IV tenectase in carotid or vertebral free-floating thrombus in window?
Repeat the question once again.
Free-floating thrombus.
Can we thrombolyze with IV tenectase in carotid or vertebral free-floating thrombus in window?
Ritesh?
Sir, it may not be ideal. So if we are definitely if the IV window less than 4 hours, if you're doing an angiogram and if you are finding a free floating thrombus, it could be mostly underlying dissection or something. So it's a little confusing situation, sir. But definitely V4 vertebral don't thrombolize. Carotid, maybe at least you can thrombolize. We can see the etiology why it's happened, whether it was a plaque rupture or a dissection. If it was dissection, we have some more information from MRI. Better not to thrombolize, because definitely that will dislodge, because usually they are very fast accumulating thrombus. So during Corona time, we had a lot of patients. I have 4 or 5 patients, young guys, post-Corona, maybe 3 or 4 weeks down, 4 or 5 carotid free floating thrombus we had. 1 or 2 we had not given IV thrombus. We just went ahead with this retrieval device and slowly aspirated and pulled it out.
Madam,
it's
can
an
I answer that
unpredictable
question?
thing. I think vertebral better not to, sir.
Madam, can I answer that question?
Yes, please.
Madam, most of us will not have access to all these cath lab setups. That is the truth. Let us face it. Absolutely. Now, we have our settings in our Apollo, everything, but that may not be possible for the majority. One of the gold rules we follow in our hospital, even when we have cath lab, is when a patient comes within 4.5 hours, CT is a workhorse for us. When you do a CT, we will not be talking about free floating thrombus, whether it is there or not. These confusions will never arise. There is no excuse not to perfuse the penumbra. This was one of the golden rules Dr. Vijayan used to always teach me. Sir, there is no excuse not to perfuse the penumbra. Just do not look for contraindications. Do a CT. Don't worry about free floating thrombus. Don't worry about what is there in the cardia, whether the thrombus is sitting there, echogenic plaque is there. Nothing you see. CT, no contraindication, lysis. If we keep it that simple, I think we will not be landing up in confusion. Of course, experts like Dr. Ritesh sir will tell us when it has not been done, but we let us not go to that level. Let us say it's simple, in my opinion. CT lysis. This is my opinion.
I totally agree with you, sir. Recently, we had a patient. This is an entirely different scenario, not in this context. It was an IV, they give an IV tenectase high dose for a stuck valve. It was a patient has missed acetrom. They given in the evening. I didn't know that. I mean, they didn't inform us. Patient, a young lady, some 35-year-old lady. Total occlusion of the basilar. Everything flown into basilar. Very unfortunate. So then again, so there are collateral evidence is saying that etiology matters, sir. I believe if it is a dissection, better not to thrombolize.
Sir,
But
no,
we
there
don't
is
have
no
the
question
information
about
most
it.
of the time.
We don't have the information. Keep it simple. And we will be successful 90% of the times. In a 10% of the time, we are not
Yes, sir.
successful.
More than
We will
90%.
not be legally wrong. We are
Definitely.
fully within the limits of law to lice these patients and leave them like that. And then experts can take over. So in our emergency, sir, we have made this absolute rule that 4.5 hours, nobody will touch them with MRI. It is CT and only CT. Nowadays, we are trying to even extend up to 6 hours to see whether we can do a CT and CT angio simultaneously. But otherwise, it is just a CT. This has worked like magic. Our door to need time has never exceeded 20 minutes. It is always the reason when it has exceeded is only when the family does not give consent. Then we have no control over that. Because of financial problems, they don't give consent. Otherwise, if it goes beyond 20 minutes, there is a fight between us. We really pick them on left, right, and center. Utilize and then talk to us. No excuse there.
SMS sir, I totally agree with your points because in most of the time in periphery or in other places only CT and if at all CT angio is there. But whether to proceed further, as Ritesh said, see if large vessel occlusion is there or basilar or any other occlusion is there, first we will give the within the window period IV tenter place, then followed by what next? See, in large vessel occlusion, most of the time basilar artery occlusion or in some M1 occlusion or in IC occlusion, the thrombus most of the time it's not dislodged. So we have to go further after that is 4.5 hours. So do IV thrombolysis with the CT angio first, then we look forward to improve further, sir. That's what Ritesh is plan to say, right, Ritesh?
Yes, we don't delay, sir. Even for if the patient agrees for IV thrombolysis, we give tenectase.
Go ahead.
Then only CT angio, because we know it's a large, high NIHS, like more than 14, 16. So we give tenectase. That's a definitely changed and helped us in the last 5-6 years. Tenectase, even in the CT console, gantry, we take the patients, family's consent, we give. It is hardly, sir, matter of 3-4 minutes. So we, when the patient is shifted for CT, tenectase, the box is with the shifting nurse, actually, the boy or the nurse who is shifting. So we don't delay. We never, as sir told, the door to needle time, though it fluctuates in the night hours, we also maybe our best time maybe 12 minutes and all we are given. But the worst time was maybe 45 minutes.
Dr. Muthukumar,
just to add,
there is
recently,
no excuse.
Sorry, just to add, just recently, it was in European ESC conference, they had shown tenecteplase was effective in basilar artery strokes also. This was just in one of their abstracts. Somebody had presented there in ESOC meeting in Helsinki.
It will be. It's the size of the thrombus and the character of the thrombus definitely matters.
See,
to the next.
There is no reason why we will not go ahead with the further procedures. We are talking about the first 4.5 hours window. That is a golden window for us.
Yes,
just
sir.
CT
First 4.5 hours, there is no question of
after that, let me finish that. So after we finish our lysis, 100%, even if the patient has completely improved, our protocol is to go for CT angio. Even if the patient is completely improved. Or sometimes we go for MR also, especially when we go beyond 6 hours, we go for MRI straight away, up to 6 hours. So first 4.5 hours, it is CT, only CT. We insist upon that. After that, you lyse, even if the patient is okay, take them for angio. And that is a time when it becomes very easy to talk, but very difficult to convince the family. When they see the patient completely okay, they ask us, do we really have to do it? That answer is presently not available with us. What happens in patients who have got low NIHSs, but they have a block, whether we should open or not, the jury is not out. But we favor that you go and open the window. That's what Dr. Ritesh sir also will agree. Am I correct, Dr. Ritesh, in this?
Time is time. We can't, we will not, we should not.
We will not leave and come back.
Agree with SMS, sir. First 4.5 hours, CT, IVT, then we can go ahead with angio, then procedure, right, sir?
Yes, sir.
Yeah. So shall we move on to the next case? I call upon Dr. Sarathi.
Sir, just one more question has come. Just one last question. Any dose alteration in stroke on DAPT?
I can answer that question, madam. It's a good question. The correct answer at present we do not know, but I will give you 2 points in this. There was a trial called the Enchanted trial. This was a trial which looked at patients who were given 0.6 milligram per kg body weight vis-a-vis 0.9 milligram per kg body weight of altiplase. Now what it showed was that 0.9 milligram per kg body weight was a correct dose for altiplase. 0.6, because there was a contention that we must use 0.6 milligram per kg body weight for Asian patients because they have got a higher chance of hemorrhage. In fact, when you look at the Japanese pharmacopoeia, it says 0.6 milligram per kg body weight. This was based on that trial. But what it showed was that irrespective of whether they were Asians or any of these things, 0.9 is the correct dose. That was one point that was established. I'll tell you why I'm telling all these things to you. 0.9 is correct dose, whether they are Asian patients, because majority of the patients in the Enchanted trial were Asian patients. And there was a reason why the conclusion came as 0.9 milligram is a correct dose. But there was one twist in this. Patients who are on dual antiplatelet therapy, these patients, when they were on 0.9 milligram per kg body weight, they had a higher chance of hemorrhage in this data. And therefore, one of the offshoots knowledge we gained from the trial was that when they are on DAPT, you may do better with 0.6 than 0.9. That was a corollary which we received. Now, extrapolating to what we have with tenecteplase. We know that the initial approval for 10 replays was only 0.2 till such time Vijay Menon said it is ACT data saying this 0.25. So all our patients receive 0.25, but when they are on dual antiplatelet, we use 0.2 milligram. This is an extrapolation again. We do not have hardcore data to accept this. Thank you.
So just to add, actually, I was talking to some of these neurologists from Japan. In Japan, they still use 0.6. I was in Vietnam some time back. They use 0.6, 0.7, and these are from the top hospitals. So although that Enchanted showed, I mean, they had a very tight margin for non-inferiority. So they established 0.9, 0.6 was found to be inferior. But talking to some of these neurologists in some of these countries, in Vietnam, sir, they say we don't go beyond, we go 0.6, 0.7. In Japan, because it is approved 0.6, they don't go beyond that. So it seems to be variable in some of these countries. This is at least just my experience talking to some of these neurologists there.
Japan, the approval is only 0.6.
0.6, yes.
We don't have a 0.9 approval in Japan.
Yeah, so they are using 0.6, and some of these countries in the Asia Pacific region, they are saying, we increase the dose, the bleeding increases. So, but this is how it is.
Yeah, may I call upon Dr. Parthasarathi, the next speaker. Dr. Parthasarathi, over to you.
Yes, sir. Can you hear me, sir?
Yeah.
Yeah, thank you, sir, for the kind introduction. So, for lack of time, I will directly go to the topic. I am not able to share because the permission is not there. Can you give me permission to share?
Yeah, please share your slides.
No, I think the host has to give me the permission.
Sir, I'm already sharing your slides. Please let
No,
me know.
I will do that from my side because I've had some edit after that. So I think you can see my slides.
Yeah.
Yeah. Good evening. I'm Dr. Parthasarathi, consultant neurologist in Apollo Adelaide Hospital, Kerala. So this is a very strange case that came to us a few months back. He is a 64-year-old male, and he was found unconscious in his field by his neighbors and was taken to a nearby hospital. From this hospital, he was referred to our hospital. So last seen normal was around 9 a.m. and he was found unconscious half an hour later. And the neighbors found him lying on the field with bowel incontinence and taken to nearby hospital where his GCS was low. So they had sedated and paralyzed and intubated him and then taken for the MRI brain. So we had a unconscious, sedated, paralyzed, intubated patient coming within window period with an MRI from outside. So we had this slightly poor quality MRI images from the outside, which shows cerebellar infarcts and basilar cutoff sign. So this now we are having a conundrum. What do? We don't have a reliable history. We just have an unconscious patient with a basilar artery occlusion. Do we proceed with this case as a stroke, or can it be something else? Is the MRI reliable? Because we don't have the report, we just have the images. And that too, not all the images, only few images were available for us. And so should we wait till the relatives come by the time the window might have closed for any sort of intervention? So this was the dilemma that we faced when the patient came to our emergency department. So what we did is, in good faith, we thought this is a stroke and nothing else. We went ahead with thrombolysis just based on the MRI images that were available for us. And following the thrombolysis, we went for a CT brain with a CT angiogram. So this was a CT angiogram taken immediately after the this thing. Here we can see, 1 second. Yeah. So if you see closely, you can see there is a crescent sign in the left vertebral artery, suggestive of a vertebral artery dissection. Are you able to see my images?
Yes, yes.
Yes.
Yes,
Yeah.
sir.
So there is a vertebral artery dissection, and when we go up, we see that the basilar has opened up. You can see here the two vertebral artery coming and joining. So here beautifully we can see the basilar artery. So I thought, okay, we have done a good job. The basilar has opened up. So now we can save the patient. That was my thought process. But then, in clinical medicine, when things can go wrong, a lot of things go wrong. In this image, you can see a little bit persisting thrombus sitting inside the basilar artery, but the flow was quite good. So, post thrombolysis, the CT is showing a good flow. The basilar artery has opened up, but there is a left vertebral artery dissection, but there is a preserved flow, and the opposite vertebral artery is patent. As the patient was sedated and paralyzed in the other hospital, we still don't clinically observe any improvement, and he is still in the ventilator. He was given vecuronium from the other hospital, so it might take few hours for us to realize whether he has improved clinically or not. So what our question is, should we do anything for the dissection or just leave it alone because now the flow has maintained, the basilar has opened up? Should we observe till this thing is the patient's paralytic agents has been worn off? Then we got the history that the patient was actually with his brother climbing like a tree to cut jackfruits when his brother, along with the jackfruit, fell on top of the patient. And the brother had sustained a fracture, and all the relatives took him to the hospital. And this guy was relatively okay initially. Then we don't know what happened. He was collapsed and was found near this jackfruit tree. That is why the history was unavailable, because none of the relatives were with him. All were with the other brother who was taken to the hospital. This patient also had a history of cervical spondylosis, and some surgery was done to the neck 7 years prior. Post thrombolysis, there was a very difficult course because he was having significant hypotension, and he was continuing to be in ventilator. But after 6 hours, he opened his eyes, but he continued to be in quadriplegic, severe hypotension and autonomic instability, and required multiple vasopressors. So at this stage, what should we do? Because the patient is continuing to be in quadriplegia. We had given optimal medical treatment. Are we missing something? Has the dissection progressed since the CT angiogram? So these were the questions that we were discussing as to what to do next. So what we did is we repeated the CT angio after the patient regained consciousness, but still being quadriplegic. So this showed a good flow through the basilar artery. It has not reoccluded. There is no significant thrombus sitting in the basilar artery or any of the superior arteries. The thrombus that was previously inside the left vertebral artery was also cleared up and the flow was good. Sorry. We observed that there is a bilateral cerebellar infarct, but not enough changes were seen in the brainstem to explain this kind of quadriplegia.
Dr. Parthasarathi, is spine done?
Yes, I'll come to that, sir. At this time, the patient was having severe hypotension, so an MRI was not possible. He was on 3 or 4 inotropes. He had significant autonomic fluctuations with poor renal output, and the quadriplegia was persisting. So after 8 days only, we were able to stabilize him for the MRI. So as you can see, unfortunately, he had developed a long segment infarct over the C-spine, lower end of the middle left, with a bilateral cerebellar infarct. This is the diffusion sequence of the C-spine showing a acute infarct with a diffusion restriction. Sorry. So what has happened was, because of the vertebral artery dissection, the anterior spinal artery went into ischemia. We think that that might be the reason for the autonomic instability and hypotension, because these fluctuations started immediately after we shifted him to the ICU. So usually the anterior spinal artery has branches coming from both vertebral arteries. Sometimes it may be dominant. One side may be dominantly supplying it, and if that artery is dissected, the anterior spinal artery entire can be involved, leading on to a long segment of spinal cord infarct, especially in the C spine. There are certain radicals that are coming from various branches of the vertebral artery. When this radicular artery is involved in the dissection, can also cause a anterior spinal artery infarct. These are the various postulates from various case reports available. The patient was taken for tracheostomy, weaned to BiPAP, remained quadriplegic, and discharged to a rehabilitation center. As you can imagine, the relatives were quite unhappy because of the 3 weeks of hospital stay, high cost of treatment, and never came back for review. So, few points to ponder. Vertebral artery dissection and carotid dissection is very rare. That is, a cervical artery dissection combined has around 1 to 2% of all ischemic thrombus strokes. But it can go up to 18% in younger populations. And vertebral artery dissection can be associated with trauma. Even minor trauma can cause dissection, or it can happen spontaneously, as in case of fibromuscular dysplasia, vascular Ehlers-Danlos syndrome, or certain call for mutations. And the mechanisms are not completely understood. Maybe the adventitia and the intima may be weak in certain connective tissue disorders. A lot of theories are there regarding how the infarct happens. Most of the times, it is an artery-to-artery embolism because of the dissection. Also, when there is a intraluminal hematoma that can compress from outside into the lumen, and that can also occlude the vessel. History of smoking, older age group, connective tissue disorders, positive family history are all risk factors. And the patient is older age and has poor prognosis compared to the younger age. Suppose the patient has a deficit within hours of the dissection or the neck pain, it has a much grave prognosis compared to later onset of stroke. So there are a few guidelines that are released by the AHA, in which they have told that we can go ahead with intravenous thrombolysis in dissection, because they have not have significant data saying that it is bad. But there are certain caveats. The evidence is not strong, and recommendation is it is not a good recommendation as per their guidelines. You have to look for certain factors before going for intravenous thrombolysis in a case of dissection. One is, if the dissection is extending intracranially, the high chance of bleed. Second is, you can miss subtle subarachnoid hemorrhage if there is a dissection. So you should specifically ask your radiologist to look for small subarachnoid hemorrhages. If missed, it can lead to a very, very big hemorrhage if you are going for a thrombolysis. And if there is a large infarct size, then also if you thrombolyze, there is a high risk of hemorrhage. If there is a large vessel occlusion, you can go ahead with a mechanical thrombectomy. And if there, in our case, the large vessel occlusion has opened up after thrombolysis, so we did not go ahead with a mechanical thrombectomy. So post thrombectomy, we can continue with antiplatelets or anticoagulation. So there are various studies regarding which to choose. So they have looked for the factors that can cause high risk of bleeding, like intracranial extension, subarachnoid hemorrhage. All these things you can go ahead with the antiplatelet. Otherwise, you can even consider anticoagulation to prevent the stroke post cervical artery dissection. You can see the anterior spinal artery supplies the anterior 2/3 of the cord. So this can lead to severe motor deficit, sympathetic dysfunction, sensory loss. All those can happen and our patient had all these findings. So this is a case that humbled us. Initially, post thrombolysis, we were quite happy because the basilar artery opened up, but finally it was quadriplegic patient. Although we were able to save the patient, but he remained quadriplegic. Thank you.
Yeah, it is a very nice presentation, Dr. Parthasarathi.
Thank you, sir.
And you have taken all the necessary steps to open up the vessel, even though the vessel is open up very well, but the end result is not a good thing. So always less than 4.5 hours, do CT brain. Then you have to do vessel imaging. See, CT angio or MR angio, and particularly in dissection, high degree of suspicion is needed. Whenever the history of injury to the neck or in the back, high degree of suspicion is needed. So vessel wall imaging, that's either CT angio or MR angio, then you will proceed further. Madam, Banu Madam, your comment?
Yes, wonderful case presentation. Without the history, his hands were very, I think, very tightly tied, I think. So, but he has done a very good job of going through all the procedures very systematically. Very good.
Thank you, madam.
SMS, sir.
Dr. Patsari, thank you very much for presenting this case.
Thank you,
really
sir.
Nice, really. And they have really gone through a nightmare, I can imagine.
Yeah.
If you have to keep the patient for 3 weeks with quadriplegia and after having done a procedure which costs 5 lakhs, it really takes guts to visit the ICU every day because they will kill you. Absolutely. No issues about it. Absolutely. No
Very difficult with the attenders also.
Very difficult. Extremely difficult. Sometimes we wonder whether we did the right thing in the first place. Absolutely. My colleague, Dr. B.R.J. Kannan, is a brilliant cardiologist. He has written one beautiful article on this. So I have written his own experience in a very similar manner, the judgment day. Maybe I can share it and that's a lesson for all of us. Thank you, Dr. Patsari. Coming to the science behind this, there are two things. One, cervical artery dissection or vertebral artery dissection. I think Dr. Amit will again, help me out in this. It is not a contraindication for IV thrombolysis. Am I correct?
Yes, SMS, sir. It is not a contraindication. Even though there is no selective guidelines, it is not a contraindication.
The recent AHA 2024, they have told that we can thrombolyze.
We can go ahead with IVT.
What I learned from was that the ultimate benefit will not be as much as in patients who did not have dissection, but the perceived risk of hemorrhage or the intramural hematoma is hardly ever seen, that we should not keep our hands tight. We should go and thrombolyze the patient in the given case. That's the first point. Am I correct, sir?
Yes, correct, sir.
The second point is about the mechanical thrombectomy. As you said, mechanical thrombectomy in cervical dissection is very useful in anterior circulation, I feel. Vertebral artery dissection, can we do a mechanical thrombectomy? Is it having any status there? Is it possible? Is it okay to do it? Because I thought it was not an okay thing to go for vertebral artery dissection, mechanical thrombectomy. Is that correct, sir?
The vessel wall injury rates are quite high when you go for a vertebral artery dissection. So I think from the case reports, what they do is they go through the opposite vertebral artery, then come down.
Yeah, comment from Ritesh.
Then.
So what Dr. Parthasarathi told you right, sir. If it is a V4 dissection, high chance of rupture and pseudoaneurysm can cause a subarachnoid hemorrhage. So what we explained, we have to go through the opposite VA. If there is a thrombus in the basilar artery, remove it. We have one case report my colleague Dr. Vikram had done when myself was there in Narayana. The patient was a young patient who had a dissection on the V4 with a pseudoaneurysm and a basilar thrombus. So thrombus was actually distally embolizing. So Vikram, what he did is he went through the opposite vertebral artery. and finally coil that stump of the V4 so that no more thrombus comes into the basilar. Of the right vertebral artery, there was a dissection, thrombus gone into the basilar, went through the left vertebral, opened the basilar, because again, we are thrombus may form, so we coil that, because it heals either by occlusion or it can heal by a pseudoaneurysm. So that VA can be a thrombogenic source. So as he told, go through the normal arteries.
Good learning point.
Regarding the etiology of this dissection, many of us tend to believe that dissection will require a significant amount of trauma. While it is true that a significant amount of trauma can result in dissection, most of the dissection cases do not have significant history of trauma, because we tend to more trauma, more chance of dissection. But statistically, if you look at that, majority of the dissections do not have significant, even minor injuries. Our teacher, Professor Dr. Jayakumar sir, used to teach us children, when they are given pencil, he says to children, we should never give pencil because they put it inside their mouth and that can produce dissection. Even coughing, sexual intercourse supposed to be a cause of dissection. Even tennis playing can produce dissection. And we have very obliging barbers, we produce dissection all the time. So trauma need not be significant enough that we should exclude dissection if there is no history of trauma. Even sometimes spontaneous dissection due to minor or unrecognized trauma can produce this. This is for the postgraduates who will be visiting here. And regarding the basilar occlusions, there is a 3 rule which we follow. The distal basilar, I believe, is the worst because that is a burdensome thing. A large clot sits there. The mid basilar is good because it is more atherosclerotic. When you have a proximal, is it a proximal basilar, Dr. Patsar, is it?
Yes, sir. Proximal basilar.
So that was a clue for us that it was neither a embolism nor it was an atherosclerosis. There was some other mechanism that proved to be dissection in your case. It is sad to know this, really.
Yes. In as per the age, they have described the etiologies. Younger age group, you can see all the Ehlers-Danlos, fibromuscular dysplasia, connective tissue disorders. In older age groups, because of the cervical spine degenerative changes, minor trauma to the neck can produce some kind of vertebral artery trauma that can dissect off.
I have seen 2 barbers induce dissections, sir. Because in Tamil Nadu it is common. They go for severe neck pain, they go and they do all the kind of massage in the this one. One of the cases was seen actually by my colleague and sent Dr. Karu, Dr. Saravanan had sent that case to us. So dissection can very well happen with the barbers. It's one of the barber chair phenomena.
Only the minor trauma dissection comes to us. The major trauma goes to the vascular surgeon.
Any other questions?
No,
Kalpita,
sir.
any other question in the box?
No, sir. No, sir. There are no questions from the audience.
Okay.
Another important point is that once you get a dissection, for next 6 months, you should ask the patient to not to bend your neck significantly, even not to sleep while sitting. Even that can produce recurrent dissection.
Give them a collar?
Yeah, preferably a collar, but the soft one, not the hard one.
Yeah.
So with this, I think we exceed the time of 10 minutes. Thank you for the Emcure for their scientific this no thrombosis national workshop session. And we thank moderators, Professor Dr. K. Banu and Dr. S. Meenakshi, and 2 eminent speakers, Dr. Ritesh Nair and Dr. Parthasarathi. So we thank one and all for this wonderful last 1 hour, 10 minutes discussion. I hope we'll see in further sessions in future. Okay, so Kalpita, you want to say something?
Thank you, sir. It was definitely a very enriching and insightful session. I think all our attendees must have learned quite a lot. So thank you, and we look forward to conducting more such sessions.
Thank you.
Thank you, sir. Thank you, madam.
Thank you so much.
Thank you.
Take care, sir. Good
Ritesh,
night.
that was brilliant.
Good night.
Ritesh Patsar, really fantastic cases. Thank you.
Thank you,
Thank you,
sir.
sir. Good night.
Thank you,
Good night.
Thank you.
Good
Thank
night.
you, madam.
Good night.
Bye.